And it did end up being useful because I had opted for the injection after the placenta, and then I had some additional bleeding on top of that. So they gave me then another kind of dose of the medication. So she actually went to inject it in my leg, and I was like, "Can you not use the IV for that?" And she was like, "Oh yeah, I forgot that was there."
Welcome to the podcast. This is Tracy Donegan. Today I'm speaking with Caoileann Appleby. Caoileann shares her frustrating experiences of accessing evidence-based care for her VBAC in Ireland and the many challenges she faced along the way. And now I bring you Caoileann Appleby.
Hi, everybody. Welcome to my next episode of my podcast. And I'd like to welcome Caoileann Appleby this evening to talk to us a little bit about her experience of Irish Maternity Services and ultimately her journey to VBAC. So welcome, Caoileann.
Thanks for having me.
Thank you for being generous with your time this evening. I know it's late there and you've got two little ones that are, I know how difficult the evenings can be, but I really do appreciate your willingness to come on and really just share a little bit about your experiences. So do you want to start off with, I guess, go back to almost the very beginning with your first little one? And
Yeah, sure. I live in the NMH Domino catchment area, and one of their community clinics is like right around the corner. So that was my first option for care in that pregnancy, which was great. Like, it was super handy, you know, having shared care between the clinic and my GP. I didn't have to go into the hospital and all, and that was great. Except then at 36 weeks, they were like, your baby feels like the baby's breech. And I was like, okay. And they were like, so we'll check again next week. And if the baby is still breech, then we need to send you, you know, you'll risk out of care and we'll need to send you into the clinic and so on and so forth. So I did all the things. I did the upside down on the ironing board, and I did the acupuncture and the burning stuff, and yeah, I did all the things. And baby, she would kind of float sideways sometimes, but then she would go back.
Right.
So when I went to the 37-week appointment, I knew she hadn't moved. I could feel she hadn't. So then I was referred into the Breech clinic the following week for an ECV. And I had done my reading. I had a friend actually who'd had a breech baby a term and a successful ECV. So she talked me through her experience. So I wasn't worried about that at all. I was happy to opt for it. But I had to advocate to have the muscle relaxant, which, because I knew kind of as a first time mom, my odds were kind of somewhere below 50% of the procedure actually working. So I wanted to kind of, you know, tip the odds in our favor if possible. And that was very weird, because the reg who was doing the clinic was immediately like, oh, we don't do that here. And I was like, oh, well, why not? Because it'll increase my success rate. And she was like, well, there was a bad outcome several years ago, so it's not protocol now. And so that was the beginning of like, oh, I'm on the dark side now. This is the bad place. So anyway, she called in the consultant, and the consultant had absolutely zero problem with it. She was like, yes, absolutely, you can have that. That's no problem. And like, the procedure itself was not uncomfortable. The reg tried, the consultant tried, but baby just did not budge. So then I wanted to discuss my options. But it was like they were surprised that I wanted that I thought there would be options. And again, this is my privilege and my luck, that I had known people outside of Ireland who had breech babies at term and who had been offered discussions about choices. But there was no discussion about choices. The consultant said, well, you can have your schedule section, or you can come in pushing. Those are your options. And I kind of said, well, you know, I'm a first-time mum. I've never been in labour before. That doesn't sound like come in pushing doesn't sound like a very safe option. And she's like, well, it's not. I was like, well, can I, you know, because she wasn't supposed to be in, you know, she was just kind of dragged in because of the muscle relaxing conversation. She wasn't. So I was kind of like, well, can I have a conversation, like a longer conversation with someone? And she was like, yeah, I'm sure that could be arranged. And then in the room with the midwife afterwards, because they monitor you after the ECV, I was kind of asking the midwife, who I'd never met before, you know, how do I go about arranging that? Because I know I'm off, the domino can't look after me now. And she was like, well, you've had your discussion. That was your discussion. So I was lucky in that, you know, I was very disappointed. I was very upset the fact that the ECV hadn't worked, and that this was then, you know, what I was being told, just rock up to your 39-week cesarean with no other choice. So luckily, and then there was no, like I was asking, you know, where do I go for my next antenatal appointment? And no one was able to tell me because I couldn't go to the Domino clinic. I was like, where am I supposed to go? And they were like, oh, we don't know. So none of that felt very, very reassuring. And I was lucky that I was able to get back in touch with the head of the Domino service, and she kind of understood where I was coming from, and she managed to kind of sneak me in for an extra meeting with another consultant, like at the end of a gynae clinic a couple of days later. Like this, you know, this consultant was doing it off her own bat. And she had a much better and longer conversation with myself and my husband, and she was like, look, we are not trained for this. She was like, we train in unplanned breech, we train breech second twin, we don't train breech labor. She's like, and I was, you know, I'm very well read, and I had looked up papers, and I was like, well, can we try the ECV again? And she was like, that's not protocol, but there's no reason why not. You know, you can go to the clinic again and try it again. But she was quite honest with me. She was like, look, this shouldn't be the situation that you're in, but we don't have that many experienced providers, and if you come in labor, any deviation will, you know, you will end up in the operating room. So at least I suppose she was honest with us about that. It wasn't what I necessarily wanted to hear. But she was happy to discuss, and that, you know, that discussion made me feel a lot better. Ironically, so we made a plan to repeat the ECV when I was 38 weeks, and then I would book in for a planned cesarean. That was the plan. About 2 hours after that meeting, when I was sitting at home on my couch, my waters broke. So that was the end of that plan. And that was actually, I suppose, mentally relieving in a way, because I knew the baby was unengaged breech. So I knew then, with the waters gone, like there's no safer option. And I wasn't in labor at all. I never had a contraction. Like I had the surgery probably nearly 24 hours later by the time they got me on the list. So that was the safest option. And in fairness, the actual surgical experience went very smoothly. Like the surgeons looked at our cesarean preference list and they chatted to us about it. Everybody talked me through what was going on. Like the actual surgery was probably the best part of that whole experience. And breastfeeding went well and so on.
Well, I guess when the waters went, when the waters went up, that kind of took the decision out of your hands. So did it feel like that was a little bit easier to accept?
I think so, yeah. I think so. So there was no decision that, because I knew.
And did you have any?
You know, the risk of cord prolapse was too high, and so
Yeah. Did you have any specific preferences for the cesarean itself?
Well, you hadn't found out the sex of the baby, so I didn't want them to announce that. I wanted, like, me to see and my husband to tell me, because I'd had hyperemesis in that pregnancy as well. I was very paranoid about feeling nauseous during the surgery, so I was asking for, like, preemptive, please just give me whatever antiemetics through the IV that you can. Like, I don't want to even be worried about feeling nauseous. I also wanted pictures of the placenta, which they thought was a bit weird, but they did for me anyway. And then the rest of the preferences are about kind of establishing breastfeeding and so on. So they were all, that was fine. They were all respected. The problem then again started once my spinal started to wear off. And it was very, very painful. Like, it was much more painful than I was expecting. And it was like a burning pain between my waist and my knees. Like, everything felt like it was on fire.
Right.
And they were very perplexed by that. They couldn't seem to, like, they offered me more pain medications, and eventually, like, you know, in the middle of the night, they had an anaesthetist come in, put in a new IV, and gave me morphine. which took the pain down by a notch or two, but also made me vomit, which then brought the pain back up again. So that didn't really help. So it was kind of, and that whole day following the surgery, it felt like it was every hour somebody would come over and go, "Oh, why haven't you mobilized yet? Why aren't you out of bed?" And they would try to get me out of bed, and I would cry in pain. And then they would look perplexed and go away and come back. And eventually another anaesthetist was called, and he kind of, they couldn't examine me. They thought maybe there was a hematoma in the scar, but it was so painful I couldn't actually let them touch me. Like, it was very, very difficult. And the second anaesthetist was like, "Well, this is nerve pain. This is nerve pain from the spinal. This has nothing to do with the wound. She needs ice. She needs an ice pack and time. That's what will fix the pain." My husband was like, "Great, okay, an answer. Yes, can we have an ice pack?" And they're like, "Oh, we don't have any ice packs." So we had to go out to Boots to find an ice pack. So the whole immediate recovery in hospital was really horrible. I just didn't feel like, anybody was believing me about the amount of pain that I was in. And luckily, like, my daughter was fine. Like, breastfeeding was going well comparatively. But I was dying to get out of there, but I couldn't walk for 2 days. Even when I went home, then I couldn't. Like, we had a little changing unit. I couldn't stand beside the changing unit long enough to change nappy for about 10 days. So I found the recovery really difficult, even though, like, I know people who've had emergency cesareans after long labours, and, they were like, "Oh, it's grand. It's grand. It's not a problem. The recovery's fine." And I just found it horrible and really difficult. So I was determined. I was probably determined to have a VBAC for my next pregnancy even before the surgery. But after the surgery, I was even more determined. I was like, I am not going through a recovery like that again.
Hey there, if you're enjoying this conversation and are passionate about evidence-based care for VBAC moms, the best way to support our work is to subscribe and share this episode with other amazing mothers in your life. Your support is so important to us and helps us reach more mothers with empowering content. So go ahead, hit that subscribe button and spread the love.
And had you ever had any like allergic reactions to pain meds in the past, or that was like all they said, an ice pack will fix
An
it?
ice pack, yeah.
Yeah.
And it did fade. It did fade. Like, the first 24 hours were certainly the worst.
Yeah.
But I spoke to another. So during my second pregnancy, I raised this as an issue. Like, this happened, and actually in the Coom, the midwife arranged for me to have a chat with one of their anaesthetists, and I described to him everything that had happened, and he was like, "What I think happened is they slightly damaged one of your nerves when they did the spinal. So they maybe went in at a slightly bad angle and slightly kind of temporarily damaged a nerve." And so I was asking him, like, what, because I've never had any back surgery. I don't have any like weird anatomical issues as far as we know. And I was asking him then about the risks of recurrence, and he was like, "Well, it's about a 1 in 10,000 chance of that happening. So yours is probably higher than that, but I can't give you an exact figure." He was like, "It's probably higher again if you have an epidural, because the epidural needle is thicker." So he was kind of saying, if you want an epidural, if that's part of your plan, get it early, because you'll be moving around less. It'll be easier to insert it if that's what you want. So I took all that into consideration, and I was still like, no, I will do my best to do it without an epidural, thank you. But that was really useful. Like, and that was much more information than I got from anybody in the first hospital, and they were just either perplexed, or they just did not believe. They just thought I was being a wimp. That was the impression that I got. So that's hence why
there's nothing worse than when you're in pain and people not believing
you. Yeah. Just not being believed is like, it's just so devastating when you're in a vulnerable, position, if you're in pain, if you're sick, and that's one of the reasons why I switched hospitals. Even though I hadn't moved, I was still in the catchment area. I was like, I won't be eligible for the Domino clinic again, because I'll be high risk or higher risk, and I just didn't. I just felt I would be starting on the back foot in that hospital. I felt like I just didn't trust them, so I wanted a clean slate. So I booked with the Coom for my second pregnancy. But the care there at first was not great either. The Coom is because I had hyperemesis.
I'm seeing a pattern.
Yeah, I had hyperemesis again, and I was lucky with that because I had a very understanding GP who got me treatment very early in my first pregnancy. And actually, when I was planning my second pregnancy, I had a script from her before I was ever pregnant for medication that I could go on, the second I got the positive test, in the hope that would mitigate the worst of it. Unfortunately, it didn't. I was actually sicker in my second pregnancy than I was in my first. And I was sent into hospital by my GP for hyperemesis, and the triage midwife, wanted me to do another urine test, even though I was very dehydrated and it was difficult to pass urine. And then she told me, based on the urine test, that I wasn't pregnant at all, and she didn't know why I was so sick. Having been sent in by my GP for hyperemesis, with a history of hyperemesis, based on a machine that goes beep, she told me I wasn't pregnant. And of course, that's, the first thing you think when you're in early pregnancy and someone tells you, well, the machine says you're not pregnant, is, am I having a miscarriage? Am I, have I been this sick for nothing? And then lo and behold, they did the scan, and there was perfectly normal pregnancy, no problems. So I was like, right, well, they gave me different medication at that visit, which didn't work either. But I just went back through my GP then for changes in my medication treatment. And there was a couple of other occasions where I should have gone in for IV rehydration, and I didn't, because I didn't want to encounter that same attitude again. And it was still, they still had kind of restrictions on partners coming in with you, and I just couldn't face doing it. So I was off work for 2 months with hyperemesis until we found medication combination that kind of worked well enough for me. Yes, it was not an auspicious beginning.
It sounds horrific. I mean, the hyperemesis, thankfully I have never experienced it. I've had the normal run of the mill warranty, but yeah, to be like, not just making the decision not to get medical care because of the stress the staff are going to put you under is just, I thought I'd heard it all, and I've heard a lot. Yeah, but that's really, really sad. That's the state we're in.
And that's kind of been my experience. Things are really mixed. The maternity care system is really mixed. Like we paid for a private kind of screening test, and I was about 10 weeks pregnant, I think, and I was so dehydrated that it took 3 people to get a blood sample. And the third one was the consultant in that clinic, who actually also works in the Coom, and he was like, you really need to go in, like I really recommend that you go in. And I was like, well, the last time they told me I wasn't pregnant and wouldn't give me an IV, so I'm not gonna. So luckily I then, in the next couple of days started taking medication that worked. But it was really mixed. And then in my booking visit, they're always very detailed, and the midwife goes through like loads and loads of history, and she was like, what are your plans for this birth, and asking me about, was I planning a repeat cesarean? And I was like, no, I'm planning a VBAC. And she was like, well, based on your history, I think you can go to the midwife clinic if that's what you want. And I was like, oh, brilliant. She was like, you just have to have like your 16-week appointment with the public obstetrics clinic, and then you can switch to the midwife clinic. And I was like, oh, brilliant. And I show up for that appointment, and the public obstetrics clinic were like, no, that's bad information. I don't know who told you that. You can't see the midwives. You're with the obstetricians. That's just how it is. And I was like, oh, okay. So I went a couple of my next antenatal appointments with the obstetric clinic, never saw the same doctor twice, got very mixed information about which appointments I should be seeing the obstetricians for and which appointments I should see my GP for. And I eventually kind of after the 22-week appointment or something like that, I ended up making a complaint to the patient liaison. Because I just had enough. Just had enough of the mixed messages and being told one thing by one person and being contradicted by someone else. And the patient liaisons were actually great, and I recommend that to everybody now. I was like, make it the hospital's problem.
Yeah.
because they were great. They spoke to me.
Mm-hmm.
And then the next time I went in, I was with the midwives clinic. And that's where I stayed for the rest of the pregnancy. Yep.
Right. Yeah, because I've seen some other discussions on the VBAC in Ireland group about moms that are considering trying to get to see the midwives. And I know several women that have managed to get to the midwives clinic, but they really had to fight for it.
Yeah.
And
it seems bizarre. And I knew going into the Coom that I wasn't in their catchment area. So I knew I wasn't eligible for their community midwife stream, but there is an in-hospital midwife stream. And yeah, you have to make yourself a bit of a pain in the arse. And that's my advice to any pregnant friends now, is like go in there with your notebook. Because that's what one of the midwives in the NMH called me the first time. She was like, "Oh, you're the patient with the notebook." I'm like, "Yes, I am." I told the midwife in the Coom, "I'm the patient taking notes. I'm taking your name." And I told the midwife in the Coom when I met her, I was like, "Look," I was just laid it out there. I was like, "Look, I'm skeptical, but I have justifiable reasons to be skeptical about medical care. So, I need you to discuss things with me. I need you to, and I laid, I will come in with my questions in my notebook." And she was like, "Okay, great." And she was fabulous. She really made an effort. The two midwives who run that clinic really made an effort to kind of understand where I was coming from and listen to what I wanted. And that made a huge difference then. Knowing that I could go in and I would see one of those midwives who had read my file and not just a random SHO or random reg, who you scan you and take your blood pressure, and then that was it. So that made a massive difference.
Mm-hmm. So then the rest of your pregnancy, once you had kind of got a handle on hyperemesis, was that managed well then for the rest of your pregnancy? And
the hyperemesis was manageable. It for me, it tends to diminish. My two pregnancies, it tends to diminish around kind of 22 weeks or so. It gets a little easier, so I was able to come off medication, but it was a condition that needed management. I think I still wasn't able to work full days in work for most of the rest of the pregnancy, because for me it's very linked to physical stress. And so if I had a bad night's sleep, which you do, in later pregnancy quite a lot, then I would be nauseous again and I would be in bed. If I didn't eat at very strict times and eat my cereal bar or a piece of toast. In my first pregnancy, I still vividly remember the first time I had a salad, which was at like 25 weeks. So my second pregnancy, I think the last time I got sick was 36 weeks because I just hadn't had breakfast on time. So while I was off the medication, and nobody was very concerned about the hyperemesis, once you're not being admitted, they don't really care. And I remember saying to my GP in my second pregnancy, I think around
out of sight, out of mind.
Exactly, yeah. If they don't have to do IVs with you, you're okay. And that's not your experience necessarily. I remember saying to my GP again around 23, 24 weeks. I hadn't put on any weight. Like I'd lost kilos and kilos in the first few weeks of pregnancy, and I still wasn't back to my pre-pregnancy weight. And again, no concern about that. So while my GP was very supportive in terms of medication, it was, I don't think the condition is taken as seriously as it needs to be.
Absolutely not. And especially for, when you're that ill and you can't literally lift your head off the pillow without wanting to throw up. Why there isn't a community-based hyperemesis clinic, or at least have a GP who can do an IV. You can at least.
It's so simple, and it's so like. And
you shouldn't have to go near the hospital.
In Dublin as well, when you have like vitamin IVs in Brown Thomas, and you feel like you have to go into the maternity hospital and beg for an IV as a hyperemesis patient. Now, NMH is quite good because they have the clinic, and Rotunda has the day ward set up. The Coom is still not great, according to reports I've seen, but that's a separate thing. But yes, once I was kind of in the midwife pathway, that they smoothed everything out a little bit, which was really helpful.
And then, so your discussions around VBAC then continued on nicely, and everyone played ball.
Yeah, they occasionally there was the occasional discussion around, like, I remember at one point, I think I was like 28 or 30 weeks or something, and I can't remember why, but that I had to go and see one of the senior regs as part of my antenatal, that they just wanted to double check something. And she started talking about induction protocols and how it was different for VBACs, and that there's all kinds of induction stuff they couldn't do. And I was like, no, hang on a second, sorry. Like, why are we talking about induction now? And she was like, oh, I'm just informing you. I was like, but I'm, like, I don't need to have this discussion now. So there was definitely, like, I think if you're not determined, it's very easy to be swayed. Like, I had a lot of things that, things in my corner when it came to planning for this. Number one, I was very determined because of my C-section recovery experience, but also the reason for C-section was non-recurring.
Yeah.
So I had no, the medical people, my GP was like, well, of course you can have a normal birth this time. There's no problem with that. So the medical people weren't giving me any, oh, well, labour didn't go so well last time, so, maybe there's something wrong with you. There was none of that, because I had no labour with the first pregnancy. I was kind of I remember saying to the obstetrician, like, I was like, look, from all my reading and all my research, I'm a first-time mum with a scar on our uterus. That's my risk profile.
Yeah. Yeah.
I was like, am I wrong? And she was like, no, that's right. I was like, okay, cool. Because we're on the same page. But you have to be very forceful about that. And you could have been easily, like, if you weren't determined or weren't knowledgeable, easily swayed by whatever random doctor, happened to decide that they didn't support you. But like I said, the midwife clinic was very helpful, and one of the things that involved a lot of discussion towards the end of my pregnancy was I didn't want continuous monitoring in labour, because I had, it's literally the machine that goes ping from the Monty Python sketch. It's just no use in the low risk labour, and it puts you at much more risk of a cesarean delivery that you didn't need and the baby didn't need. But it's so embedded in hospital culture that it was really, and it's like, as a VBAC patient, you're treated as more risky, even though if you're like me, there's no inherent risk in me. It wasn't like I was very old or had, difficult blood pressure or gestational diabetes or anything like that. So it was, and luckily again, the midwife was very supportive. She was like, look, I understand your reasoning. You're not wrong about the evidence. She's like, I, as a midwife, prefer not having to watch the machine. She's like, it's easier to look after a woman when you're looking at her and not the machine. But she was like, I don't have the authority to sign this off. So it has to be signed off by a senior obstetrician. You have to have a discussion with her, and you will likely have to sign an against medical recommendations form. So that meeting then all had to be arranged. But again, I think, I was worked up about it because it was very important to me. But the consultant, and what I did find as well is that the more senior the clinician, the more able and willing they were to have a discussion around risks and benefits and nuances and personal preferences. Like the junior regs or the SHOs, it was by the book, tick, 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 or the staff midwives, tick, 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 tick. Whereas the senior midwives and the consultants that I met, in both hospitals, were much more willing to go, well, yes, that's true. Have you considered X? Or you're right about that. What we are concerned about is this. Like, it was much more discursive as opposed to like, we just don't. That's not what we do here.
Yeah, there's a conversation to be had.
Yeah, exactly. And especially around CTG, I knew I was right. I knew I was right about the evidence. They couldn't kind of, and they didn't contradict me on that. But they were weighing the risk differently. They were, I was looking at it as like, look, there's a very small risk of a catastrophic problem that continuous monitoring may detect 10 minutes earlier than just a midwife with a sonic aid. But the much more likely thing to happen is that I will have another cesarean that I didn't need. Whereas they are thinking about it.
Yeah.
And so I was looking at my own individual risk. They are thinking about it on a volume level. And they were like, well, in their heads, they're like, well, if everybody did what she did, then we're going to have, a uterine rupture that we couldn't detect, and I'm going to get sued. And that's what's in their head.
Yeah. Yes.
So I understand where.
Yeah, it's litigation.
Yeah. I understand where they were coming from, and I can understand. Like, I've read I wanted to go into this well informed. I've read descriptions of uterine ruptures when they happen and how dangerous they can be. But I only have to have this baby once. They have to be the supervising doctor for hundreds and thousands of pregnancies. So they are seeing it differently.
Yeah.
And I knew as well, for the type of labour experience that I wanted, I didn't want to be strapped to the machine. And as well, I find it really funny, peculiar that everybody was so intent on me having continuous monitoring in labour, but yet in the much higher risk situation I was in my first pregnancy, when I had an unengaged breech baby and rupture of membranes, I think there was something like a 1 in 20 chance of cause prolapse, which is also a catastrophic event that requires an emergency cesarean delivery.
Yes.
And no, I was not continuously monitored in the 24 hours before that delivery. I was just sitting on the antenatal ward. Every so often they would come over and listen, and it was fine. But I was not continuously monitored then, in a situation which is an order of magnitude more likely than a uterine rupture in labour.
Yeah.
So I was like, the maths isn't mathing, like, doesn't make sense.
Yeah. Nope.
So anyway, we had this discussion. I signed against medical recommendations form that was put in my file. It was in my birth preferences, which are also my file. The sign off from my doula was also in my file. Everything was in there. And yeah, so I knew, kind of, again, going back to I'm a first time mum, I knew I would probably go past my due date, because I hadn't been in labour before. And that turned out to be the case. But I just missed, I knew at my 40-week appointment, I was like, if I'm still here next week, you guys are going to want to talk to me about induction, right? And they were like, yes, we will have to have that conversation and document it. I was like, okay, all right. She was born 6 hours before that 41-week appointment. It was just by the skin of our teeth. Yes.
Yeah. I hear a lot of these babies are, once induction is on the card, they're like, yeah, peace out.
Yeah.
I'm coming.
Yeah, I know. And then my personal bias is I don't know anybody who had an induction who had a good experience. Not one. Yeah, I know
they do happen.
But I just I personally know people who've had emergency cesareans, instrumental deliveries, PTSD, shoulder dystocia, baby ending up with an acute, all of these kind of. I personally know those people, and I was just like, oh God, I just don't want to end up in that situation if I can possibly avoid it.
And we see the birth trauma rates going up as well. So
and it's really it's very frustrating because I don't think it has to be that way. It makes the whole, I really felt throughout the whole pregnancy, look, I have to be on it. I have to be on my toes. I have to be very articulate. And it made me feel for, people who don't have those advantages, who haven't had access to the reading. And I have, friends and family who are doctors who I can be like, am I reading this correctly? And they would be like, yes, don't have those resources. English isn't their first language. All of these kind of advantages that I had on my side, for sure, and the ability to pay a doula. And had we, my first plan for the second birth actually was, I was like, well, can I get a private midwife and have the option of a home birth? Because I knew obviously I was out of the HSE criteria and I couldn't because there was no availability. So, so my plan for the labour was stay at home as long as I can. And that is what ended up happening, which is great. You know, I kind of the vast majority of time I was in labour, I was, you know, either chilling out or asleep. There was probably only
That's a nice way to labour.
yeah. It was I kind of went into labour in the middle of the night and kind of woke up and noticed some contractions and then just went back to sleep. And then for most of the rest of the day, I just had kind of contractions maybe every 10 minutes, very easy to cope with. And like my daughter got home from creche and my husband was like, you know, this has gone on all day now, like these haven't stopped. Do you want her, because the plan was she was going to go to my parents for the night. He was like, do you want her to, you know, do you want your parents to come and pick her up? And this is at like 6 o'clock. And I was like, I honestly don't know. Like I could go to sleep. I could sleep through this again if they stay like this.
Yeah.
So I was like, no, just put her to bed as normal. But by 10 o'clock, I was definitely like, you know, it was getting much more intense, you know, much more focus needed to kind of cope with everything. And so my husband called my parents and came and picked her up. But I was still like, I think I'd done so much prep, like I had so many coping methods on hand that there was always kind of a next stage at home. You know, when distraction stopped working, I had the TENS machine and that helped a bit. And when that stopped helping, we got a birth pool from our doula. So I got into the birth pool for a while. And then I held off on calling the doula to our house because I was like, that's my next stage of help. And I don't feel like I need her yet. Like the birth pool was helping. And I also found tracking contractions really annoying. So I didn't do it. I was just like, no, I don't want with everything. I just, no. So it's actually my husband who noticed. He was like, the contractions are like every 2 or 3 minutes. He was kind of like, oh, this is the point at which, oh, he was like, oh no, we should be going into hospital now, shouldn't we? Should we? And he was asking me, he was like, what do you think? And I was kind of like, fuck off. Don't make me make a decision. I don't want to make a decision. But
Can I ask you, when you recognize that, labor, this is it, labor started, was there a feeling of relief that, because that, you know, those last couple of days, weeks and days, and you're like, is it, you know, that induction is looming there, it's just this cloud that's there. So did you have, like, when you thought, actually it started and it's happening?
Yeah, there was definitely like a relief and a kind of like, you know, an excitement in early labor. You're kind of like, oh, this is great. And I felt prepared as well, like, you know, in as much as you can, having never experienced labor before. Like I felt like I had my coping methods. I had my stuff, you know, set up. My husband was as reasonably prepped as he could be. Like we had the doula to call, like all of that was all lined up. I still maintain that I think we went into hospital a little bit too soon. Because my husband was nervous and I didn't want to make the decision, and my doula wasn't there yet. You know, like she wasn't observing me or anything. And he was kind of like, no, I think we need to go.
Right.
I remember we got into the car and he said, okay, the Coom is like 13 minutes drive away according to Google. And I was like, okay, well, that's 4 contractions. I was like, okay, I can do 4 contractions in the car. He took the long way. He missed the turn. That extra 2 minutes, I nearly killed him. But the worst part of the whole labor was getting checked.
That's not the time to be choosing a different route.
I know. I had my eyes closed when I opened them and I was like, why hasn't he turned? The worst part of the whole labor was getting checked into the hospital, because, you know, this was at midnight. Then you're like, the maternity hospital, they must be used to women showing up at all hours of the day and night.
Sure.
No, they kept us in the lobby while they went off and looked for my file. And so I was throwing up in the lobby from labor. The poor security man behind the desk was like, oh my God. And then we got up to the triage, and because COVID rules were still in place, you know, they wouldn't let my husband and my doula in with me. And my main pain relief method at that point was my husband just pressing on my hips really, really hard. So it was much harder to cope with the pain without him there. And they tried to do the 20-minute trace with the CTG. And I kept saying, no, check my file. No, I refused that. And it was like she didn't believe me, but she needed the file. And it was, 20 minutes before the file came up from the archives below or whatever. And she was like, you have to get on the bed to get this monitoring. And I was like, I'm not getting on the bed. I'm not getting monitoring. Like, you can hold it on. So overall, that was like an hour and I was like, can my husband come in? There's no one else here. And the midwife was like, no, he's not allowed. But so it wasn't until my file came up and she actually read my file and saw, the obstetrician's signature and on my birth plan and everything that she switched completely. And then it was like dim lighting and, you're doing really well. Do you want gas and air? But it was about probably
but if somebody hadn't vouched for you,
exactly.
If you were
again
had walked in the door and just made that decision,
not believed until you have the authority endorsing you. And even still, like, they want to do a vaginal exam, which I knew would happen, and I didn't really mind. But again, you have to get up on the bed to be examined, and that was very painful. And I was like, I was most comfortable standing, and I was like, can you not just examine me here? And they were like, no, we can't. I was like, why not? Like, who trained you? But anyway,
they can.
So that was
was
the worst. That was the worst part of it. Once we were in the delivery room, we got a very relaxed midwife. She was very chilled. She was not at all worried that I was VBAC or whatever. She was not at all worried by not having continuous monitoring. At one point, she did come in and say, the doctor on call wants to talk to you about monitoring. And she kind of had a look on her face like, oh, the doctor on call, your man, I have to say this.
She's like, don't shoot the messenger.
Exactly. Yeah. And my husband was like, no, we signed the form. We don't want to talk about it. And that was it. So that was very chilled. And luckily and happily, the labor proceeded very well. I had when I say the admissions part was the worst part, that was where I didn't like gas and air. I had been taken away from my main pain coping method, which was my husband. Doula wasn't there. Doula wasn't allowed to be in with me. And in triage, I asked for an epidural because I was like, they had assessed me and they'd said, well, you're 3 centimeters and that's great. And I was like, oh, fuck it. I can't. I can't. I'm not mentally able to do an indefinite number of hours at this intensity. So in triage, I asked for an epidural. By the time we got to the delivery room, again, I was back with my coping methods, and I was coping a little better. And the midwife was kind of like, look, I know you've asked for the epidural, but I think you're actually a lot further along now. And do you mind if I do another exam? And I was kind of like, okay. And I was 9 centimeters then. So I had gone from 3 to 9 in an hour and a half, maybe. And then once I heard that, I was like, oh, this makes sense then, because the intensity I was feeling didn't match up with 3 centimeters with early labor for me. And once I heard how far along I was, it kind of almost made me relax. I was like, oh, well, this makes more sense, and I can totally do this. Which was great.
Yeah.
Which was nice.
Yeah. So to be told, you're 9. It's like, oh, yes.
Yeah.
We're almost there.
Yeah.
We're almost there.
Yeah. And so she was born 3 hours after we got to the hospital. Yeah. So luckily kind of.
And did you have anything else in your birth preferences that might raise eyebrows other than, doula and intermittent monitoring? Was there anything else there that?
No, I don't think so. I had things like, I want to be in whatever position feels comfortable to me. I want to leave the cord until it stops pulsing. That I don't think raised too many eyebrows. No. I did want an IV put in, because I have bad veins, and I was like, in the event of an emergency or them needing to put an IV in, I would rather it's already there than them spend 10 minutes finding a vein. So I had that done in triage. And actually, this is like after the switch point for that admissions midwife, because she was like, you know, you don't need any IV. You know, you're doing really well. And I was like, well, it's in my preferences. Like, just do it.
Yeah. And you have good reason for it, especially with the hyperemesis. You know, it's like, if I need something to hit this nausea quickly, I want to be ready to go. Yeah.
And I also kind of felt like I did want it, but I also felt like having that in my birth preferences was almost like a bargaining chip that was a kind of a signal for the medical staff that I wasn't against intervention, that I'm not like, you know, dismissing everything they're doing, but that I am making deliberate choices about what interventions I do and don't want. Now, whether they took it that way, I don't know, but that's how.
Throw them a bone.
Yeah, exactly. And it did end up being useful because I had opted for the injection after the placenta, and then I had some additional bleeding on top of that. So they gave me then another kind of dose of the medication. So she actually went to inject it in my leg, and I was like, "Can you not use the IV for that?" And she was like, "Oh yeah, I forgot that was there." Yeah. So no, I mean the actual birth was great, and I'm still kind of, it's such a good memory. Like I'm so like, while it wasn't totally perfect, like if I had the option of a home birth, that's what I would have done, and I think it would have been less stressful for sure. But I think we did as well as we could in the hospital environment, and you know, luck plays into it as well. Obviously, preparation plays into it, but you know, I didn't have any medication. I didn't need it apart from to help with the bleeding a little bit. I didn't need any stitches. The immediate post-birth recovery was incredibly different. Like so she was born at just before 3 a.m, and I was rolled down to the postnatal ward at about 6:30, and my husband went home then to get some sleep. And I was like sitting up on the bed, walking to the toilet, like walking around, holding the baby, like which I couldn't do for ages and ages after my first daughter was born. Like sitting cross-legged on the bed, I was like, what? Able to like turn around and pick up the baby myself. So the immediate recovery was so different, and then I was dying to get out of there, absolutely dying to get out of there. And lucky it was the day of the clinic, my midwife's clinic, so she came up at the start of her shift. She'd obviously seen I was in, and she came up and she was like, well done you, this is great, I won't be seeing you later this morning, so and then she was like, do you want to go home? And I was like, yes please, can you arrange for me to go home today? And she was like, yeah, I'll sort it out. So we went home like 12 hours after the birth.
And did your doula get to come in with you at all, or they just, because it was COVID?
She did come into the delivery room. Yeah, she was allowed in delivery. Yeah.
Oh, good.
Yeah. And she was really helpful. She was actually, I know she was there. I don't remember, because a lot of things are like, once you get into the delivery room, it's kind of the most intense part of the labor, and I don't remember a huge amount about it. I mostly remember my husband. But she was really handy as well for like immediately after birth, like helping me shower and helping me like get everything organized. It was just great to have another person on your side that you know is unquestionably on your side. Because I think it's difficult for partners.
And who understands the system a bit.
Yeah. And you know, my husband is super supportive. Like, he was born at home himself. His sister had a home birth. So he was very chill. He was very like, no doubt in his mind that I could do whatever I wanted to do, and that was no problem. But during the actual labor, I think it did freak him out more than he was expecting. Like, I don't think he expected it to be intense, as physically intense on me as it was, if that makes sense.
Yeah.
And so I think he was a little bit like, oh God, I've got a job to do, but this is really strange. So I think having the doula there, I think, helped keep him calm, because he then knew there was someone else. It wasn't just up to him to kind of make decisions and protect me, that there was somebody else.
It makes such a difference.
Yeah. So
just even having somebody there that will remember what you learned in your classes, or knows like the right questions to ask, especially, based on what your preferences are, and help you kind of
and like
navigate.
Suggest, like at one point, because I had been most comfortable kind of standing up and leaning over the bed. I remember saying at one point, I was like, I'm not comfortable anymore. I was like, I can't relax my muscles. And so she was really good at kind of suggesting like a different position to be in that would feel comfortable, but still like get me more relaxed. So yeah, it was, it was great to have her there. I think it did help. And I think also, in a cynical way, I think medical staff as well are more careful when there's a doula in the room. Because they probably know the doula is watching. But like I said, the actual midwife.
Yeah, it is. I think it is one of the reasons why the doulas are. I think it's one of the reasons why the doulas are still not being. They just want to ignore the evidence, and because I've had this conversation multiple times with the hospitals, and they did not want an independent witness in the birth room. So it's like, okay, if you're practicing midwifery and you're following, the hospital guidelines, you still have to have a conversation with mother about, informed decision making and all of that. But it's having that doula there, even if they're saying nothing, is incredibly powerful.
Yeah.
And it really shows that you have done as much as you can to stack those odds in your favor.
Yeah. And I think that's.
But it's frustrating that they continue to ignore it.
And I think stacking the odds was a really good framework for it, because you can't control everything. Like, some things are just a roll of the dice. And so, like, for me, it was really helpful to have a kind of a plan A, plan B, plan C, written down in my birth preferences. And again, I think it helped to show them, look, I'm not anti-intervention. I don't want, I'm not here for a pain-free birth with dolphins or whatever stereotype. I had like a plan A birth. I had a plan B. If I have an epidural, these are the alternatives then that I want. And then I had if I need a cesarean, this is how I want it to go. So that was all really helpful. I felt like I had prepared as much as possible, and actually doing that then allowed me to relax when I was in labor, because I felt like I've done all the things. I've done all the prep. This is not an exam. I cannot study anymore. You just gotta, you're on the roller coaster now, and you just gotta breathe. Like that's kind of how that's the analogy that comes to mind about labor. It's a very physically intense experience, like painful as well, obviously, but I think more intense than painful. And it's that mental ability to stay as relaxed as you possibly can with that intensity and not panic. That's the main skill, I suppose. And I was saying that,
and I think, and the fact that you got to experience firsthand when your support was taken away from you, how the intensity increases significantly, and you can see how, again, if it was someone on their first pregnancy and they're thinking, oh my God, I'm not coping, it's like, well, we've just taken your support away from you. Well, no shit, Sherlock, like that. And the staff then, they're not recognizing that this woman is in distress because we've sent her only form of support away. Like if they did it with the epidural and said, no, if with COVID, no epidural, there would have been riots in the streets. But not recognizing the partners as a core part of that birth team was such a mistake.
Yeah, it's huge. Yeah. I've lost my train of thought there, but one of the things I found out as well is I got my notes afterwards as well, and one of the things I found out was that at that first exam where they said, oh, you're 3 centimeters, I was actually fully effaced, but they didn't tell me that, and I didn't think to ask. And I think had I known that, because I knew that's for a first time labor, that takes the longest, and had I known that, I think I probably wouldn't have panicked at that point. So again, it's and maybe had my doula been in the room for that exam, she would have asked and I would have known. So it's knowing the right questions to ask is really, and you can't do it in labor. Like, you can barely speak it's very hard to, have an articulate conversation with someone. You can't do it. And the same when you're very sick with hyperemesis as well. Like, there would be days, my sister would text me and go, "Can I call you?" And I would be like, "No, I'm sorry." I would text her back going, "No, I'm sorry. If I talk, I will vomit." And so it's very hard in that situation to, go into hospital and attempt to advocate for yourself. Like, it's very difficult.
Yeah, it's impossible, really. It is. And that's not impossible, but it is. You cannot you can't be in labor and discussing the evidence or arguing about CTG. So this is, and there's one of the reasons why I wanted to do this series with mums who have done as much as they could to prepare for VBAC in Ireland, but it's just not an easy process to navigate, and it is so dependent on who you meet on the day, whether they've had their Weetabix, and and whether they're doula supportive,
and whether the reg has been given out to you by a consultant recently and they're feeling scared.
Yeah, I mean, and I can see both sides. If somebody has had a bad outcome, then they're going to be skittish about some things, but you have to be able to look at the evidence, and you have to be able to have a conversation with the patients about, and it just seems to be very adversarial to have that conversation, or to ask for anything that is, and not outside of the norm, but anything, like, all you're asking for is evidence-based care.
Yeah.
Like, that shouldn't be such a shock to everybody that when you ask for, "Oh, I want intermittent monitoring, I'm not having continuous monitoring," that they'll say, "Oh yeah, I understand why. It's this push, and you're just stressed from the very first appointment."
Yeah.
But what would you say to somebody who's watching this now and thinking, "Okay, I really feel strongly about having this," because not everybody does. Mm-hmm. So, but if you really feel strongly about it, what would you say to, parents that are watching tonight saying, "Okay, what can we do to really stack the odds in our favor?" Based on your experiences, what would your suggestions be?
I think definitely an independent class. Ideally an independent VBAC class. And do the hospital one as well, because that will give you information on what they want. But an independent class will give you many more options, and give you a kind of a framework for your questions. Because you shouldn't have to be, you shouldn't have to have a PhD in medical history to, have your preferences respected.
No.
So an independent class, like a doula, is a huge resource as well. Like, I was so well read, I was almost overly well read. Like, I didn't use my doula as a resource, but I know she had a lot of that information, or she could certainly point me towards sources for information. So, if you don't have time, or don't have the skills, or mentally don't want to do all that research yourself, a doula can be a really good resource for that. And then, finding ways to relax in the midst of it all, I suppose. Because I think I've referenced it. I'm quite a planner, and I, at a certain stage, I had to say to myself, I was like, "Look, you're not going to get an A+ in birth, okay? Like, there's no more studying to do. You have done your best to get the right team, to be in the right place. You've got everything written down and signed off in triplicate, and at a certain point, you just have to let it go then." Yeah. But I think for me, more information is better. And I was much more confident in my decisions because I had looked at the pros and cons and the risks and benefits. I think it's possibly a bit easier to be swayed if you don't have that knowledge base, or know where to go with that. Yep. But I think in a way I was lucky to be so determined. But I'm I think.
No,
go ahead.
Is there anything you would do differently?
Like I said, if I could have got a private midwife, I would have.
Stayed home.
I would have gone into the hospital slightly later. I think I maybe would have waited for the doula to come to our house, and then go in rather than, because I think if I had arrived just that hour later, they would have recognized more quickly how advanced I was. And that very stressful hour, maybe wouldn't have happened in that particular way. But by and large, like, I think I did the best I could, and I'm certainly like, I'm so proud of myself. I'm so delighted. It's such a happy memory. And you feel like a badass. It's a badass thing to do.
Yeah. It really is.
I feel like, and I work out, I lift weights a lot, and that also is a badass thing. But I feel like you can't tell me nothing. I've had a baby without pain meds, so which is not obviously not everybody wants that or needs that. But it was definitely a plus for me, having been able to have that experience. Is I was delighted with that.
Yeah, and it's not even. I mean, of course, labor is intense in itself, but the fact that there's all of this messing around in the months leading up to it, just trying to get VBAC support from the hospitals. It's like, why do you have to make things so difficult?
It should be normal.
Labor is hard enough.
It should be normal
without having to go through all of this stress. Yeah.
Like, it should be as normal as any other kind of delivery. Like, there's no reason necessarily to treat it as super high risk. And I know in America the context is slightly different, and you have the small hospitals which say, well, we won't do VBACs, and you're kind of like, oh, look, either you can cope with an obstetric emergency or you can't. There's nothing. Obstetrics emergencies obviously do happen, and stats C-sections do need to happen, but there's nothing particularly special about VBAC in that context. Like, you should just be able to have a normal pregnancy and a normal delivery if that's what you want.
Wouldn't it be lovely to just say, yeah, I'm having a VBAC, and everyone go, oh, great, and that's the end of the conversation.
Like, even my mother.
It's not a, oh, you are.
Yeah, like, even my mother, who was, her advice on birth was don't go in until the baby's nearly here, because they will just mess with you. That was her. That when I was born, apparently she was in the hospital 20 minutes before I was born. So that was her attitude. But even she didn't realize that I was allowed to have a vaginal delivery after cesarean. She was like, oh, is that it? Are you allowed to do that? And what are your chances? And I was like, about the same as any first time mum. The same as any first time labor. Mm-hmm. Like, it's not a high risk. It's not a high risk thing. And
your risk level is rather the same as a first time mom, but your mental health risk is probably going to be significantly higher when you're dealing with all the nonsense and the pushback and defensiveness. Yeah, so just be prepared for the stress levels if you're not in a 100% pro VBAC bubble.
No, you're breaking up a bit.
I can't
hear you. Sorry, I didn't catch that last bit.
No, I was just saying that it would be lovely if we could just have, women are in this lovely VBAC bubble in the maternity units where they're treated normally and not treated as a really serious incident that's just waiting to happen, which is how it kind of currently is. There's no normality around it. There's no, oh, you're having a VBAC, great, and it's, oh, you wouldn't have why don't you have another cesarean? It's easier and we can plan it. And there seems to be that idea still in Ireland about what you're allowed to do.
Yeah. And this kind of, very stringent adherence to hospital policy and guidelines, even though no hospital policy or guidelines should overrule your informed consent. And even the guidelines themselves, when you look at them in detail, actually say the evidence for this recommendation is weak. Like, this is not an evidence-based recommendation, this is a practice-based recommendation. But you have to dig in, you have to go and look at the version for doctors to find that out, because the version for patients doesn't have that. So it shouldn't be such a battle, you know. So yeah, go in prepared, bring a notebook, let them see you take the notebook out.
And it shouldn't be
and
a
ask for
lottery
everybody's name. My other advice.
who you
They
meet on
don't
the
often
day, whether
introduce
they'll be
themselves.
supportive or not.
But if you have to make a complaint, then the name is very useful. Bring a notebook and let them see you write down what they're saying and ask for their name. Yeah.
And the notebook is such a good idea, because, or just even put your notes in your phone, because like I've seen this over the years where mom will be in one VBAC in antenatal meeting and they'll be told, oh, you know, do you know your uterus could just explode suddenly and it's so dangerous, and your risk is 1 in, you know, I think 1 in 200 was what they were saying at the time. And that was when the first set of guidelines, the 2012 guidelines, came out. And yeah, it was just, nobody really did anything with them then until last year's new version came out. But we're still looking at low level evidence for many of their recommendations.
Yeah, and in that context, and I think one of my friends, who was a doctor herself and then had a traumatic birth experience, what she said to me is, she was like, obstetrics, she was shocked as a patient, because in her role as a doctor, it's expected that she will, you know, almost make the case for a recommendation to a patient, and she will go through, you know, this is what I am recommending and why. This is why I think it's a good idea. These are the side effects you can expect. If you don't, you know, your other options are A, B, and C, and these are the risks and side effects of those options. And like, what would you like to do? You know, how do you think this treatment is going to affect your life? Like, she's used to it's expected of her to be able to have those conversations and guide those conversations with patients. And as a patient, she was like, there was nothing like that. You know, and I reflect on my first, you know, the cesarean birth. You know, you're not even given a leaflet afterwards on recovery. You've just had a major abdominal surgery and you're not even given a leaflet on what's normal and what's not normal. You know, I had bruising across my stomach and I was like, is this normal? Maybe. The end of the stitches came out of the side of the scar when it was healing, and I was like, again, is this normal? Is this something I have to go back to the hospital for? Like, what is, like, there's no guidance about recovery, and they don't. There's just no room for discussion, and I think some of that is cultural in obstetrics, and I think some of that is resources, that they're so pressed for time, and so understaffed, and it's easy to see that, especially I think in the postnatal wards, it's really easy to see how understaffed they are. Like, you know, the woman in the bed next to me, in the Coom, she didn't have her baby with her. He was in the NICU, and she asked the midwife on the postnatal ward, you know, I wanted to breastfeed, but how do I breastfeed without my baby? And the midwife said, well, the baby will be fine however you feed them. The baby will be fine on formula. Because you could just see she had so much to do and she just did not have the time. She was just like, and maybe in her head that was being reassuring to that patient, but actually what it was incredibly unsupportive and dismissive to this woman, like, who was saying, I want to do this, and then she was being told, oh, it doesn't matter. When it clearly does matter to a baby who's in the NICU that they get breast milk. Like, it's bizarre sometimes, the thing.
And it's almost another reason for bringing in volunteers or bringing in doulas, because I've seen when I did my training, and you're on postnatal, and especially with the level of intervention, I can't even imagine what it's like now. So you might have, maybe on a 6-bedded ward, maybe you'd have 2 cesareans, you know, but now, like, if you're trying to provide quality care to women and babies, and you have what are we at, like in some cases 50 to 60% induction rates and cesarean rates that are just like, now you have a ward where you have 50% women who've had a surgical birth and need like really a lot more care, and then you have the women who've had the vaginal birth who now they don't have support for breastfeeding. They're just kind of get on with it because the system has now focused on, we're just going to keep this medical model going, and the midwives will just have to deal with it.
Yeah. And it's, I think it's very obvious as a patient as well that the midwives don't have a lot of authority within the hospital system. Like even that very senior midwife in the Coom, she was not empowered to sign off on no monitoring. Like that had to be signed off by an obstetrician. And there was a few things that she had to be like, I have to document that you have spoken to an obstetrician about this. So that's very frustrating as well.
It's a lot of covering your backside.
Yeah. And it's just not very, it's not patient centered, and it's certainly not coming out in outcomes. Like we have very high surgery rates and very high intervention rates. I'm sure very high rates of, trauma, even if it's not diagnosable as a clinical condition. Our neonatal death rates are not improving in line with those at all. So what is it for? And I mean, I don't know what the fix is. I'm just a patient.
A long way to go.
Yeah. But you do feel like, it's certainly my overriding feeling as a patient, both, in terms of birth and in terms of hyperemesis, was you have to fight to be believed. And you have to fight to be taken seriously. And if, like, I'm not having another baby, because hyperemesis will do that to you. If I was, I would almost make sure private midwives were free and then get pregnant, right? Because I don't think, like, it would just be a lot easier. It would just be a lot easier.
Yeah, and this is the thing. Like, it should be easier. Yeah. This idea that somebody senior has to sign off on you making an informed decision or informed refusal, is just bizarre. We're not talking about, you're not 5.
Yeah.
We're talking about grown-ass women here who are just trying to have the safest birth that they can. They got to fight every step of the way. Unless, you get that unicorn VBAC.
Yeah. And I do think, like, a lot of the midwives I met, some of the midwives I met were not great. A lot of them are trying their best. And similarly, like, some of the obstetricians are clearly very invested in patient-centered care and, want to have those discussions with you, and others are not empowered to. They are just, or don't see the need. So it's very mixed. It's a very mixed picture. So it's just a lot harder than it is. I'm still delighted that I made the decisions I did and things went the way they did for us. But it shouldn't be such a fight. And you shouldn't, and even something like the guidelines are guidelines, they're not laws, and policy is policy, not law. And it should still be up to you what decisions you make.
Yeah, absolutely. And just before we wrap up, just going back to I'm going to think of you now as the notebook, the notebook girl. But really documenting for your own notes, that when you're given a number, when you're given a figure about uterine rupture or whatever the figure is, write it down, because chances are you'll come in another couple of weeks and someone will give you a different figure. And just to be able to, and you see the inconsistency of the information that you're being given. And it's also helpful then for future discussions that you've taken notes. Why wouldn't you have a notebook? There's a lot happening during these appointments. And I think especially as you're getting closer to the end and you might be a little bit kind of stressed going into the appointment. And when you're stressed, of course, you're not really listening and you're not taking in a lot of the information, so having that notebook, I think, is quite helpful.
Yeah.
And not being afraid to ask for the midwife or doctor's name and ask them for their PIN number or ask them for their medical council number. Because when I've seen women that are being bullied in labor, asking this question, can I please, or, repeating whatever your decision has been. I have made a decision. I am not having continuous monitoring. Please look at my notes, whatever. We're not discussing this. But even to have that conversation in labor is just, one thing that's going to set your adrenaline off and stall everything is that discussion. So having a clued in partner that will say, hey, can we talk outside about the birth preferences and not be afraid of asking for identifying details or asking for a new midwife.
Yeah.
If you are not feeling the love and you have tried your best to make this work, don't worry about anyone being offended. You get this one chance to do this and to really, do it under your own steam. But sometimes staff are just not receptive to it. And like you said, there are some brilliant midwives, brilliant obstetricians who are patient-centered, mother-centered, focused on the evidence. But there's also lots out there that just really, maybe they're in the wrong job, maybe they're just burned out, they just aren't interested. And you'll know when the vibe when you're sitting talking to somebody, if they are truly VBAC supportive and are they actually hearing what you're saying or not.
Yeah, absolutely. And I think even just asking the name sometimes can stop them and make them take a step back and go, oh yes, no, sorry, I am in a rush and I was just trying to tick the boxes and I need to talk to you like you're a person. I'm trying to think, do I have anything else to add? No. I don't think so. I think that's probably everything.
This has been great. I really do appreciate you spending time with me this late evening and sharing your experiences. I think I had just bumped up in the VBAC group your preferences about the monitoring, because of course it's something that always comes up, and to have an example of what you can put in your preferences. But for anybody watching, make sure you have a discussion about those preferences long before the big day, because you do not want to be rocking into Holles Street or the Coom with preferences asking for, anything that's going to raise an eyebrow is just going to add additional stress on a day when you really want to minimize stress.
And having, even as something as simple as having the doctor's signature on the plan can help.
Yeah. And have a copy of that in your bag. Yeah. Because if it takes them 3 days to go down to the archives to find it, in the meantime, they're looking at you going, are you telling fibs?
Bring on electronic records. Yeah.
Do all
of that, and you have time during pregnancy to do this research and make these decisions most of the time. So by, and that was actually one of the things that I couldn't get a straight answer on in early pregnancy was like, when can I have a birth plan discussion? Because I was like, I'm going to request a longer appointment so that, I'm not holding everybody up by having an extra time. And they couldn't give me a straight answer on when was the most appropriate time to do that.
But what's amazing for me, Caoileann, listening to your experience, is that at each step of the way, you weren't being unreasonable. Yeah. You weren't asking, could you, swing from the chandeliers and introduce risks that might, have everyone a bit twitchy. Yeah. You were really asking for something very, very simple. Respect, communication, evidence-based care. It's not that difficult.
Yeah. Like one of the things I had on my birth preferences was, if you're suggesting a change to my care, tell me the odds of the outcome, that you're trying to mitigate against. Like, is this a common thing, or is this a rare thing? And can you give it to me in figures? And people were very perplexed by that. And I was like, I'm not looking, this is not an exam. I'm not going to come back later, but I'm looking for an indication of, if you're recommending an intervention to prevent some outcome, like how common actually is that outcome? And that was apparently a very perplexing request to have on. But that's how I make decisions. That's a really vital part of making a decision about care, is how dangerous is this risk and how common is it? And if I don't have a part of that
And
puzzle, how can I make that decision correctly? But there's
you can't make it, and this is the thing, you cannot make an informed decision if you don't have all the facts, and that's part of the national consent policy.
And it seems to be particularly around induction. Like I was, like I said, I avoided that discussion. But I've had friends who've been told, like, oh, well, you'll come in for an induction at this point. And, unless you know to ask the question, that's what you'll do, And then and I don't understand the economics of it either, of like, so many people being referred for induction, which takes much longer, which takes up beds, which puts additional pressures on. I don't understand how the maths work, quite apart from the patient autonomy argument. And you're told, oh, you must have an induction. And then you go in, and then they're like, oh, well, sorry, we don't have a bed for you for 3 days. And then you're in a panic because you're told you must, it's dangerous to continue pregnancy, but they're telling you to go home.
Or they'll tell you, this risk, and it's like, but nobody's talking about what's the absolute risk, or are we talking about relative risk? Don't ask that question, because they'll blow a gasket. Again, Caoileann, your problem is you were too well informed. You knew too much, and then not everybody likes that. I've had moms that have said to me, "Oh, they told me you've been reading too many books."
Have you been Googling this?
Okay.
Like, yes, I have, because I haven't gotten any information from you guys. Where else am I supposed to get the information? And there is some crap information out there for sure, and there are like very airy-fairy websites of like, all you have to do is just believe, like your Tinkerbell, and that's doing a massive disservice, to people as well. But it shouldn't be that hard to get information and have an informed discussion. And I don't think people object to doctors and midwives making recommendations. That's they are more experienced than us, and we rely on them to kind of guide us. That's not a problem. But to say that, like, there's very few situations, medical situations and obstetric situations, where there are no choices. Like, there are some, but there's very few, and VBAC certainly isn't one of them, and continuous monitoring certainly isn't one of them. So it's like there should be a lot more room for that.
Well, we're starting to see some changes. We're seeing some midwife-led VBAC clinics. So slowly.
Okay.
But for me, it's just not happening quick enough. I've been running the group for a while now, and it's I just see it, especially since COVID, it's just gotten 10 times worse.
So many of the same questions
really
come up. All the time. And like, what I find amazing around the discussion around kind of breech delivery in my first pregnancy was, like, I couldn't believe that I was being told, we are undertrained, therefore you will have surgery. I was kind of like, what? That's not my fault. That's not my fault that you're not trained. Like, why?
Get trained.
And then it's a self-perpetuating problem, obviously, because we've had decades of obstetricians who are not trained. It just, it's like you say, it's all happening a bit too slowly. And you have to be very, very determined.
And that's exactly what you were, and I'm sure that part of your personality really significantly contributed to having such. I mean, getting to the finish line. Really, it's very, very really difficult today. But I think hearing your story and your experiences, and I think hopefully it will, I guess, gives parents a little bit better understanding of what you're faced with, and I hope that I'm going to get loads of comments on this video saying that wasn't my experience. My experience was amazing. I want people to say, no, Tracy, you got it wrong, and I would love to be wrong and just say, I got it all wrong. VBAC is, of course, the normal care pathway for healthy, well women and babies, and they're cheerleading you on, but we're not there yet.
No, we're not there. No. And the same with hyperemesis treatment as well. Like, I would love to say that it's easy for women to access medication through their GP, that they are believed about how sick they are, you know, but still it's too common for, you know, patients to really struggle. And then, you know, the later you get treatment, the worse things can get. So yeah, it's a different condition. Obviously, it's nothing to do with VBAC, but it's still within the same system, and you see the same problems.
Yeah, and I would love to talk to you again, Caoileann, about your work with Hyperemesis Ireland, and I think that would be really fascinating discussion to have. I've been following, you know, I guess the last kind of year, was it the last year or two, with the trying to get the medication signed off, and
yeah. So that's progressed, but it's still ongoing. Yeah. But we can have another chat about that. another hour and a half long chat about it.
Thank you so much. I know. This is because I'm gonna. No, I could sit and chat all night, but I know you have better things to be doing. But thank you again for spending the time with me tonight and sharing your experiences. I think it'll be really helpful for a lot of parents to really understand. This is kind of the reality for a lot of women that are trying for VBAC. But there are pockets, you know, where things are getting better, and there are staff that really do care, and they are out there. It's just trying to connect with those staff.
Yeah. And I think the earlier you can, or like the more determined you can show yourself to be, I think the quicker the medical staff get on board. So yeah, well that was my experience as well. But yeah, I hope it's been helpful for people, and given them an indication of kind of what questions they should be asking, or even just, like I said, to know that you have choices. If you don't know that you have choices, there is no choice. So yeah,
exactly. And I think it'll be also helpful for midwives and doctors and consultants to have a look at this as well and see what's actually happening on their watch.
I hope so. Yeah.
Thanks so much, Caoileann.
Thank you.
Thank you so much for tuning into today's episode. Remember, empowerment begins with knowledge. If you enjoyed our time together and want more content like this, don't forget to like, subscribe, and share with your friends. Stay inspired, stay informed, and until next time, take care of yourself.